Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some tips which may prove very handy in your line of duty. So I welcome you all to part 109 of our pharmacotherapy MCQ series, majoring in infectious diseases. Welcome. The first question reads, Mr. AKM, a 39-year-old male patient, presents to your accident and emergency department. He has a past medical history of asthma and tension headaches. Today, he has a chief complaint of photophobia, neck pain, and headache that he describes as a different type of headache from his normal headaches. A lumbar puncture is performed, and empiric therapy for treatment of bacterial meningitis is initiated by your team. After 48 hours, the microbiologist calls the infectious diseases consultant treating Mr. AKM to report that the CSF culture is positive for Streptococcus pneumoniae, which has penicillin MIC of 0.5 mcg per ml. This patient has no known drug or food allergies. So my question to you is, which of the antibiotics below would be the most appropriate for AKM's treatment following the release of the lab reports by your microbiologist? Would it be vancomycin, penicillin, cefotaxime, or cefotaxime plus vancomycin? I'll give you 10 seconds to choose the correct answer. So C, cefotaxime, is the correct answer. Now, the IDSA guidelines for bacterial meningitis state that a third-generation cephalosporin is the agent of choice for bacterial meningitis due to Streptococcus pneumoniae with a penicillin MIC of between 0.1 and 1 micrograms per ml. Remember, our fellow here has an MIC of 0.5. It falls in that range. Now, ampicillin or penicillin is recommended when the MIC is less than 0.1 mics per ml. I'd like to add that vancomycin plus a third-generation cephalosporin is recommended when the MIC is equal to or above 2 mics per ml. So all those many words disqualify alternatives A, B, and D. Let's move to the next question, please. And it reads, Mr. OTP, a middle-aged male patient, presents to your accident and emergency department. His chief complaint today is extreme fatigue, dyspnea on exertion, and generalized weakness. A physical exam is done, and it shows there is pharyngitis, there is cervical lymph node enlargement. He has fatigue and fever. So my question to you is, which of the etiologies listed below is the most probable cause of this clinical picture? Is it Ebola? Is it avian influenza A? Is it infectious mononucleosis? Or is it viral rhinitis? I'll give you 10 seconds to choose the correct answer. IM it is. Now, typical symptoms of infectious mononucleosis, abbreviated as IM, usually appear 4 to 6 weeks after infection. And symptoms may develop slowly and may not all occur at the same time. They may not occur simultaneously. And these symptoms include extreme fatigue, fever, sore throat, head and body aches, swollen lymph nodes in the neck and in the armpit, swollen liver or even spleen or both, and even rashes could occur. Now the common cold virus, the common cold, which is viral rhinitis, is the one they're referring to in D. It's one of the most common infectious diseases in humans, and its typical symptoms include runny nose, congestion, and sneezing. So it would not be the best answer to this question. Then the Ebola virus disease, abbreviated as EVD, is a rare and deadly disease, most commonly affecting people and non-human primates. And its signs and symptoms include fever, severe headache, fatigue, muscle pain, vomiting, diarrhea, stomach pain, or unexplained bleeding or bruising. So that also makes it an unlikely answer to this question. Then avian influenza A occurs naturally among wild aquatic birds and can infect domestic poultry and other birds and animal species. And avian flu virus rarely infects humans. And the signs and symptoms may include conjunctivitis, influenza-like illness, nausea, abdominal pain, diarrhea, vomiting, severe respiratory illness, neurologic changes, and the involvement of other organ systems. So just like to re-emphasize that infectious mononucleosis, IM, is a contagious disease. And Epstein-Barr virus, EBV, is the most common cause of IM, though other viruses can also cause it. It is common among teenagers and adults, especially college students. And at least 1 in 4 teenagers and young adults who get infected with EBV will develop IM, infectious mononucleosis. I would like to add that IM is more commonly seen in developed countries because the age at acquisition of primary EBV infection is older than it is in the developing world. Let's move to the next question, please. And the next question reads, BMW. A breast cancer patient is scheduled to receive TAC, that is docetaxel, doxorubicin, and cyclophosphamide chemotherapy every 3 weeks. My question to you is, which of the strategies listed below would you implement to reduce BMW's risks of developing febrile neutropenia? Would you opt to start pegfilgrastim at a dose of 6 mg sub-Q on the same day as chemotherapy? Or would you begin filgrastim at a dose of 300 mg sub-Q on day 2 and day 8 after chemotherapy? Or would you settle for pegfilgrastim at a dose of 6 mg sub-Q on the day after chemotherapy? Or is it true that growth factors are not indicated with chemotherapy regimens? I'll give you 10 seconds to choose the correct answer. C is the correct answer. I would initiate pegfilgrastim at a dose of 6 milligrams subcutaneously on the day after chemotherapy. Remember, TAC chemotherapy is considered a high-risk regimen for causing febrile neutropenia. The risk for causing febrile neutropenia in this particular regimen is greater than 20%, if I remember well. And I would like to remind you that filgrastim isn't indicated to be used for only 2 doses. It is dosed at 5 mics per kilo sub-Q daily to begin the day after chemotherapy and to continue until count recovery. So that makes alternative B wrong. And remember, pegfilgrastim should also be given the day after chemotherapy, since if it's administered on the same day as chemotherapy, the patient will still be at a greater risk of neutropenia. Let's move to the next question, please. Next question reads, Mrs. DMN, a 47-year-old female patient, presents to your clinic with pyelonephritis. She is stable and doesn't require admission according to the consultant on duty. She is allergic to penicillins, and the last time she took them, she had hives. She currently takes metformin, and the rate of fluoroquinolone-resistant uropathogens in her community is 15%. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. DMN now? Would you choose to treat her with 500 milligrams of levofloxacin taken orally together with a single dose of ceftriaxone 1 gram administered IV stat, or would you settle for 500 milligrams of levofloxacin taken orally once a day, or would you administer 750 milligrams of levofloxacin orally once a day alongside a single dose of ceftriaxone 1 gram administered IV, or would you opt to administer 750 milligrams of levofloxacin orally once daily? I'll give you 10 seconds to choose the correct answer. I would opt to administer 750 milligrams of levofloxacin orally once daily after administering a single shot of ceftriaxone at a dose of 1 gram IV. Now remember, the IDSA guidelines recommend levofloxacin 750 milligrams orally once a day for 5 days for patients with pyelonephritis. Now in communities with resistant rates of above 10, a start dose of ceftriaxone or an aminoglycoside such as amikacin, tobramycin, or gentamicin may be added. Let's move to the next question, please. And it reads, Mrs. KTB, a 57-year-old female patient, develops a left foot osteomyelitis due to Escherichia coli. The admitting physician initiates therapy with ceftriaxone. She undergoes an elective surgery, and the surgical report indicates there is residual infected, though viable bone. So my question to you is, for how long should this therapy with ceftriaxone last? Should it go for 15 weeks, 3 weeks, 6 weeks, or 10 weeks? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. According to the IDSA guidelines, 6 weeks is the most appropriate duration for a residual infected but viable bone. All the others are wrong. Let's move to the next question, please. And the next question reads, several physicians at your hospital approach you as the clinical pharmacist specialist in the infectious diseases team to make recommendations to them for an appropriate empiric antibiotic regimen for intra-abdominal infections, which will be appropriate regardless of severity. My question to you is, which of the regimens listed below would you recommend to them? Would you recommend tigecycline, or would you recommend cefazolin plus metronidazole, or would you settle for levofloxacin plus metronidazole, or would you recommend imipenem cilastatin? I'll give you 10 seconds to choose the correct answer. I would recommend levofloxacin plus metronidazole. Remember, that duo is recommended by the IDSA guidelines for both mild to moderate and high severity intra-abdominal infections. Now, alternative B, cefazolin plus metronidazole, as well as tigecycline, are only recommended for mild to moderate infections. I'd like to remind you that imipenem cilastatin is only recommended for high severity infections. It's a last resort regimen. Let's move to the next slide, please. And the next question reads, Mrs. ZBO, a 76-year-old female patient, is admitted to your medical ICU. The infectious diseases team has been managing her case. They diagnosed her with VAP and have been treating her with cefepime and vancomycin for 5 days without improvement. Today, the microbiologist informs them that the culture has turned positive for Candida albicans. Currently, she's on norepinephrine, propofol, lorazepam, and she receives nutrition via TPN. So my question to you is, which of the therapeutic options listed below would be the most appropriate for ZBO now? Would it be posaconazole, fluconazole, micafungin, or liposomal amphotericin B? I'll give you 10 seconds to choose the correct answer. So micafungin it would be. Now, the use of echinocandins is recommended in patients with moderately severe illness and in patients who have received prior azole therapy. Transitioning the patient to fluconazole once she is clinically stable is appropriate since the Candida albicans isolate is likely susceptible to fluconazole. I would like to comment that liposomal amphotericin B, alternative D that is acceptable, but only when other options are not acceptable due to tolerability issues or due to drug availability. Now, alternative A, which is posaconazole, marketed as Noxafil, is only available in an oral dosage formulation, and it isn't recommended for patients who require IV drug administration. So it would be a wrong choice for this particular patient. So all those many words qualify C, micafungin, as our best bet. Let's move to the next question, please. And it reads, Mr. GTM, a 45-year-old male patient, presents to your endocrinology clinic with a moderate diabetic foot infection. He currently takes glyburide, metformin, and aspirin. He's allergic to morphine, and we are told the last time he took morphine, he had constipation. So my question to you is, which of the therapeutic options listed below should Mr. GTM be treated with? Would you opt for tigecycline, ciprofloxacin, coamoxiclav augmentin, or cefalexin? I'll give you 10 seconds to choose the correct answer. I would settle for coamoxiclav, and I'll tell you why. Ciprofloxacin doesn't possess clinically reliable activity against gram-positive cocci, so it would need to be combined with clindamycin for a patient such as GTM's case. Now, cefalexin is an option for patients with mild diabetic foot infections, and then tigecycline alternative A may be a reasonable option for pathogens responsible for moderate diabetic foot infections. There is only very little clinical data available to support its use for these patients in addition. Now, oral therapy is preferable for treatment of outpatients such as this one. Therefore, coamoxiclav, in my opinion, is the best option for GTM's management. Let's move to the next question, please. And it reads, Mr. DOT, a 66-year-old male patient, is admitted to the general medical ward with pyelonephritis. The infectious diseases team initiates therapy with ceftriaxone at a dose of 1 gram infused over 30 minutes on a daily basis. Some of the pertinent labs include urine cultures that are positive for a pan-sensitive Escherichia coli isolate. So my question to you is, for what duration should Mr. DOT be treated with ceftriaxone via the IV route? Should it be for 21 days, 14 days, 3 days, or 1 week? I'll give you 10 seconds to choose the correct answer. Mr. DOT should be treated for 2 weeks. Remember, the 7-day duration of therapy will be appropriate for fluoroquinolones in pyelonephritis, and a 10 to 14-day duration of therapy is suitable for Betalactams according to most guidelines. That makes B the correct answer. Let's move to the next question, please. And it reads, Mrs. L.I.B., a 55-year-old female patient, received a 10-day course of metronidazole for Clostridioides difficile at your hospital. Today, she presents to your accident and emergency department with a chief complaint of more profuse watery diarrhea. You perform a PCR test for C. diff, which returns positive, and WBC is 10.5 times 10 power 3. Serum creatinine is 1.1. At baseline it was 0.9. So my question to you is, which of the regimens listed below would you use to manage this episode of Clostridioides difficile? Would you settle for fidaxomicin? Would you settle for a fecal transplantation? Would you settle for vancomycin oral? Or would you administer vancomycin orally and infuse metronidazole? I'll give you 10 seconds to choose the correct answer. I would choose to administer oral vancomycin. Now, the revised SHARE/IDSA guidelines for Clostridioides difficile infection state that the second recurrence should be treated with oral vancomycin or fidaxomicin for at least 10 days. And if oral vancomycin was used initially, it should be used in this recurrence. Then after 10 days of treatment, the dosing should be tapered each week for 5 more weeks. And if fidaxomicin were to be used, it would be used for 10 days without taper. And historically, it's recorded that 6 to 25% of patients treated for C. diff experience at least one additional episode. So incidences of recurrence are not rare. They do happen. Let's move to the next question, please. And it reads, Mr. TKT, a 79-year-old male patient, is admitted to your general medical ward following a diagnosis of CAP. He has no known significant past medical history and no known drug or food allergies. Currently takes multivitamins for supplementation. So my question to you is, which of the regimens listed below would you consider the most appropriate for Mr. TKT's management? Would you treat him with penicillin and vancomycin? Would you settle for cefuroxime and erythromycin? Would you settle for amoxicillin and clarithromycin? Or would you settle for cefazolin and azithromycin? I'll give you 10 seconds to choose the correct answer. I would opt to treat him with amoxicillin and clarithromycin. The IDSA CAP guidelines recommend a beta-lactam plus a macrolide for inpatients with CAP when these patients do not need ICU care. Now, preferred beta-lactams are ceftriaxone, cefotaxime, amoxicillin, and even ampicillin. Now, ertapenem can be used in select cases. And the respiratory fluoroquinolones such as levofloxacin at a dose of 750 milligrams orally once daily or moxifloxacin at a dose of 400 milligrams once daily are the only agents recommended as monotherapy for these patients. Then I would like to remind you that this is because beta-lactams don't cover their typical pathogens, and therefore we have to pay attention to the fact that macrolides also are experiencing increased rates of resistance by the Streptococcus pneumoniae in some geographical regions, so they also can't be used as monotherapy. It's necessary to combine them with beta-lactams. I would just like to repeat that strep pneumo doesn't produce beta-lactamases. So beta-lactamase inhibitors are not mandatory. They are not needed in treatment. That's why amoxicillin combined with the clarithromycin can work effectively. Let's move to the next question, please. And it reads, Mrs. XPD, a 40-year-old female patient, develops her first episode of Clostridioides difficile during her current admission at your hospital. The labs show a WBC of 13,500, a serum creatinine of 1.2. At baseline it was 1. So my question to you is, which of the therapeutic options listed below would be the most appropriate for XPD's treatment now? Would you settle for fecal microbiota transplantation, abbreviated as FMT, or would you treat her with the 500 milligrams of vancomycin administered orally 4 times daily for 10 days, or would you settle for fidaxomicin at a dose of 200 milligrams orally twice daily for 10 days, or would you opt to treat with 200 milligrams of fidaxomicin twice daily for 5 days? I'll give you 10 seconds to choose the correct answer. C would be the correct answer. Choose to treat her with fidaxomicin at a dose of 200 milligrams taken orally twice daily for 10 days. Remember, the revised SHARE/IDSA guidelines for Clostridioides difficile infection state that the second recurrence should be treated with vancomycin or fidaxomicin for at least 10 days. Now, the oral vancomycin dose should be 125 milligrams orally 4 times daily for at least 10 days. So the 500 is a bit on the higher side. It's for more severe episodes. Now, fecal microbiota transplantation, FMT, is generally reserved for multiple recurrences of Clostridioides difficile infections and not for the first or the second occurrence. So all those many ones qualify C as the correct answer. Let's move to the next slide. And the next question reads, Mr. JHG, a 37-year-old male patient, is admitted to your general medical ward with a mild to moderate intra-abdominal infection. This gentleman is allergic to penicillins. The last time he received penicillins, he developed a rash. Currently, he administers Humulin 70/30 for his type 2 diabetes mellitus. He is stable, so my question to you is, which of the therapeutic options listed below would be the most appropriate for JHG's treatment now? Would you treat him with levofloxacin, gemifloxacin, moxifloxacin, or ciprofloxacin? I'll give you 10 seconds to choose the correct answer. I would settle for moxifloxacin, Avelox. It is the only fluoroquinolone recommended as monotherapy for patients with mild to moderate intra-abdominal infections. None of the other fluoroquinolones listed above are recommended as monotherapy for patients with severe intra-abdominal infections, so that disqualifies them. Those many words justify why C would be our best option in this particular clinical scenario. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it and to share it widely with your peers, and to leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you sincerely for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in the next video. Thank you.